The other question now, we can advise patients on what to do in terms of protecting themselves, protecting their family. But one of the difficulties that the patients really come to us for are treatment. They want to know whether or not they're going to get better, but they also want to know what we can do to help. Well, the truth is, because of the difficulties in doing the research, the best treatment for smell loss right now is really time. With the passage of time, people generally get better. And Beverly has hinted at this by saying basically that there is a remarkable regenerative capacity for the sense of smell. I will say, though, that the human sense of smell doesn't enjoy nearly the capacity that other animal species do. Other animals can't survive without their sense of smell, so they have an incredibly robust regenerative function. As humans, we've lost some of that regenerative function. In fact, when we look at the data from our center, what we see is that there is improved function in really not that high a percentage of folks who suffer an acute sensory neural smell loss. Folks with upper respiratory infections only recover 50% of the time at least some smell function. The other 50% of the time, they're essentially still anosmic, and they really don't recover any of their function in terms of their sense of smell. And for head trauma, the statistics are generally worse. In head trauma, only 1 out of 5 people will have any substantial recovery from a total loss of sense of smell. So even though time can help to heal some of the wounds, it's not necessarily the answer. So what are some of the other things that are out there? What are some of the other treatments in terms of smell loss? Well, the classic treatment, which we see every week in the clinic, is someone is trying zinc for their loss of sense of smell. And this is something that was popularized in the 60s and 70s, but basically there has never been a study that has been done that actually shows that taking zinc will improve your sense of smell once you've suffered a smell deficit. There have also been studies that have been published that are one-off studies, so to speak. They have one small study that has shown a bit of improvement. These are studies that have been done with minocycline and with alpha-lipoic acid. And unfortunately, those studies have also not been replicated. So in a number of different centers, when alpha-lipoic acid has been given to patients who have lost their sense of smell, they haven't had any improvement. And as I said, some of the problem is really getting to the patients soon enough. But in general, these are the things that people are trying, but really haven't been effective. What may work? Well, there have been a lot of studies done in terms of nerve regeneration with glucocorticoids. So high doses of steroids, given intravenously or given orally, have been shown to help in injuries to the spinal cord and in other neurodegenerative type of illnesses. So logically, if one can give high-dose steroids at the time of the smell insult, at the time of the viral infection, potentially you can have a benefit. There have been some studies that have looked at giving oral steroids to patients, but unfortunately those studies are actually confounded by not knowing the exact etiology. When the etiology tends to be polyposis or nasal sinus disease, there tends to be a substantial recovery. But for pure viral loss, we're not so sure that that's going to be effective. Nonetheless, when we have patients that present early on with their loss of sense of smell, I favor giving oral medications, oral glucocorticoids, in order to try to jumpstart the sense of smell, so to speak. I also have patients that have lost their sense of smell and then are regaining their sense of smell. And in those patients, anecdotally, when they have a cold, after having already a smell loss and starting to recover, we give them glucocorticoids in order to treat that, to try to prevent another drop or another insult to the smell system. We don't have good data to show that that's effective, but it makes sense. There are some researchers that have also talked about giving theophylline and pentoxifylline, these medications, in order to restore the sense of smell. The jury is still out. It's really only one center that has had success, Dr. Henkin and his colleagues, in terms of treating individuals with theophylline. And currently, he has been using intranasal theophylline and has had some success, but with very small numbers of patients, 10 to 12 in the published studies. So perhaps this may have a future. What we have looked at Monell is actually the role that vitamin A plays in the loss of sense of smell and the development of smell. And it plays an important role in the embryonic development of the central nervous system and particularly the olfactory pathway. There is also a postnatal differentiation of the olfactory system. In other words, smell is a learned type of sense, just as vision is, and retinoic acid appears to have a benefit or is needed for that to occur. And it also seems to be involved in gene expression in regenerating olfactory neurons in adults. So the recommendation for vitamin A is 4,000 international units in women, 5,000 international units in men. Most individuals do get substantial vitamin A in their diet if they have a balanced diet or if they take a supplement. There is a limit, though, to how much vitamin A you can take. Vitamin A is concentrated in the liver, and one little-known historical fact, Admiral Byrd, on his expedition to the North Pole, everybody on that expedition died. And they died because they ate polar bear liver, which is extraordinarily high in vitamin A, and they basically died from vitamin A poisoning. They never made it, essentially, because of that. So you can't let patients take huge quantities. Vitamin A can't be given in sufficient doses, and pharmacologically, vitamin A is only available as a drug called vesinoid, which is actually reserved for individuals that can't process vitamin A and absorb vitamin A in their diet, and they become vitamin A deficient, and so they need the vesinoid. But in general, we can't give large enough doses to be safe to cause this kind of effect. What we've done is we've told our patients to take beta-carotene each day, and we've told them to take the beta-carotene because the beta-carotene actually at 25,000 units a day is safe, and it will at least maintain what level of retinoic acid is necessary as a cofactor. But we don't have good studies to show that that is effective. There are lots of anecdotal reports in the literature of other means of recovering your sense of smell. There are actually several documented studies from China that show that acupuncture can be used to recover the sense of smell. We don't have a mechanism for that, but there are data there that are inviting and perhaps of further research. But, you know, the question is there something that, apart from me as a physician, that I can prescribe? Is there something that an individual that's lost their sense of smell can do? Beverly, what is the latest on that?
So the kind of big new thing is olfactory training. Olfaction is, in many ways, as said, a learned sense. And olfactory exposure and training have been shown to improve olfactory discrimination and sensitivity in both human and animal models. Only recently has this idea been applied to the potential for helping patients who've lost their sense of smell. And there have been 4 or 5 studies at this point that have shown that at least some patients with olfactory losses that are in those studies, they were either due to URI, head injury, or Parkinson's, can benefit from twice daily exposure to 4 odors. The 4 odors that have always been used were quite frankly rather arbitrarily chosen. But there are rose odor, eucalyptus, lemon, and clove. But as I said, not everybody seems to benefit from this. Maybe 30% of the patients seem to show improvement. And there are a lot of things we don't know about it. What types of patients are the most likely to benefit? Can the effect possibly be enhanced by using different odors or more odors, or by adding a cognitive component. These patients are just told to sniff these things twice a day. Maybe if they had a game to play with them, if they had to discriminate them, if they had to label them. There is some evidence that that enhances the training effect, at least in normal subjects. And finally, we have no idea how long-lived the effect is, whether this is something people have to do for the rest of their lives or for what period of time they need to do it. On the other hand, it's a simple enough thing to do and doesn't have any adverse effects, and so I think it's a reasonable thing to suggest to patients.
Yeah, I've suggested it to a number of patients, and they look at me and they say basically, "Are you serious? I can't smell anything. What am I smelling?" And so it does require a little bit of faith, and most of the patients, however, are frustrated, really, really frustrated by their loss of sense of smell, and they're very willing to do this. So I would encourage you to tell the patients to do exactly that. The odors that are in the literature are the ones that Beverly has described. I will say that the odors that I typically suggest are a little bit different. I usually ask them to use a scented or flower or cologne that they are commonly used to smelling, because I think that if you're used to the smell, then perhaps there is an inherent processing that can be reawakened. I say coffee, and the reason I use coffee grounds is because they're easy, and coffee is generally a pure odorant, one that you can use to actually test somebody's sense of smell. Citrus smell, as suggested there, because those are usually easy as well. Orange peel, or you can get orange peel itself in a container in McCormick Spices, and cloves, which are easy to get in McCormick Spices as well. And if you have those set out, then the patients literally will spend 20 seconds or so smelling each one of those twice a day. And I will say that at first I was very skeptical when I read this research, but it does two things. One, it actually works in 30% of the patients, which is very important. But two, it gives the patient a sense of mastery over the condition. And that is extraordinarily important, because they really are very frustrated that there is nothing that they can do. And so finally you're saying, yes, there is something that we can do. But when we really look at it, we've entitled this symposium Anosmia, a Sense of Hope. And so far, we really haven't given you much in terms of hope for the future and hope for the recovery in patients who have lost their sense of smell. So actually, I'm going to ask Mira to speak to this and some of the very exciting research that we're pursuing here at Jefferson and Monell, using stem cells to recover some of the sense of smell.
Thank you. So just to give you a very brief background about what stem cells are. So what defines a cell as a stem cell? Very important characteristics, two of those. The first one is the ability of a stem cell to make more of themselves, so their ability to replenish themselves. And the second characteristic being their ability to generate a different type of cell. So in research, every time I get asked this question, so you work on stem cells, that must be a very ethical thing you're going through. So actually, stem cells that we use are adult stem cells, and there's also embryonic stem cells. So these are the main types of stem cells that people use in research. The embryonic stem cells, as the name implies, is obtained from an embryo, and these are pluripotent, meaning that they can generate different organs as well as tissues. And the main purpose of embryonic stem cells is for the fetus to develop. The second type that we study is adult stem cells, and adult stem cells are very restricted in the areas that they're found. So examples like bone marrow is very high in stem cells, and also skin, hair, all these places have stem cells. The main purpose of adult stem cells is to help when we have any sort of injury. So if you want to recover from sort of injury, for instance, if you have scarring or if you have some injury on your skin, that's when the stem cells come into picture and help that wound heal. Now, olfactory epithelium, which we've spoken about quite a bit, also has stem cells. Now, the way olfactory epithelium is organized, I know Beverly's gone over it. So basically, olfactory epithelium is laminar, so it has an apical part, and a basal part to it. The basal part comprises of the stem cells, which are orange ones here, and then these stem cells differentiate into these olfactory neurons. The neurons are the ones that are detecting odors. There's also support cells in the olfactory epithelium. So every time there is any sort of odorant around in the nasal passage, it's specific neurons that are excited because of these odors. So that's what distinguishes if we're smelling coffee versus vanilla or strawberry, because only a subset of neurons get activated. So we know that the olfactory epithelium constantly regenerates. So every 60 days or so, these neurons die, and the stem cells and the progenitor cells replenish the lost neurons. So how can we take this and try to do something in vitro? So basically, how can we replicate this in a culture, in a petri dish? So what we have done is we have established collaboration with Dr. Pribitkin here, and we've been getting biopsy tissues from patients. So the idea is that we want to isolate these olfactory stem cells from individuals who are healthy. We want to grow them in a petri dish. We want to identify factors that can generate olfactory neurons from these stem cells. The idea being that if we can replicate this in a culture, we can eventually transplant these into the nose of an anosmic person who's probably lost a lot of tissue and hope to regain their lost sense of smell. So this is the overall goal for the project. Where we are right now is we have been obtaining biopsy tissues from Dr. Pribitkin, and we grow them into these olfactory neurosphere cultures. So basically what you see here is usually they're like balls and spheres. They have these stem cells in the center, and they have mature differentiated cells around the stem cells. The idea being that they're trying to replicate what you see in a tissue where the stem cells are usually protected from damage. So we have been growing these spheres from different patients, and what you see here is that this left video, I don't know if you can click on it. Yeah, so this is from a patient who was undergoing surgery for, I think it was DCR, and this was a 75-year-old male. You can see that this guy here is very happy. He has this beating cilia, and that's propelling these cultures to move in the culture condition, whereas this one here is pretty quiet and not interested in moving around. So basically this one has these beating cilia on it, and that's probably respiratory tissue right there because of the ciliated cells. But this one looks more like an olfactory derived tissue. Whereas this one here is from a 35-year-old female, and she has a history of smoking. But there's no ciliated cells here. That could be due to her smoking status. Also, these could be olfactory cells. So moving forward, what we do know is that the tissues that we're getting do provide us with some kind of olfactory cells. And our strategy is to enrich these olfactory cultures and hopefully identify factors that will enable us to differentiate them into functional neurons. So with that, conclude.
This is very, very exciting research. I mean, the truth is that for those of us who have worked in the field of smell research over the last 2 decades, there have been very, very few successes in terms of trying to manipulate the sense of smell for recovery. This actually provides us with 2 different avenues for success. One is to determine what are the factors that are actually relevant for the regeneration of the olfactory epithelium. If you can identify the factors that are required for the regeneration or growth of olfactory epithelium, then perhaps you can actually manipulate the environment in an individual's nose to help to regenerate those structures. The other is obviously the actual possibility of an olfactory transplant of some type, or an implant, I should say, where we take stem cells, we culture them, we grow the olfactory neurons or progenitor cells, and then actually introduce them back into an individual's nose so that they can recover their sense of smell. And this is really where we, I think, are headed in the future, is to look specifically at these kinds of biological manipulations, whether they be outside of the body or within the body, in order to restore the sense of smell. And that's really where the theme of a sense of hope comes from, that's really what we're hoping to do with this program and with our movement during the Anosmia Awareness Day, to let people know about the research that's being done and to let folks know that really, for the first time, we really have an avenue for potential success in restoring the sense of smell. So I want to thank our panelists, and we will take some questions. Questions from the audience at all? Dr. Eisman?
You mentioned that there are about 6 million people that suffer from anosmia. Am I correct on that?
Yes. Well, I mean, that's an estimate.
Approximately.
Yeah.
What percentage of that are people who are born with anosmia?
You know, it's probably a small percentage. We're actually, one of the other prongs of our anosmia initiative is to try to understand congenital anosmia better. Over the years, I mean, people have always thought it was a very rare condition, and really the only one syndrome that's particularly well known is Kallman's, which has a lot of other signs and symptoms as well. But I have over the years, you know, been contacted by a lot of congenital anosmics, some of whom have it in their family history, some of whom don't. So we don't really know, but I don't think it's quite as rare as people have assumed it was.
So when you test, for example, those olfactory tests that you use
Mm-hmm.
in children, 3-year-olds, 4-year-olds, do you find large, or what kind of percentage do you see that fail the test, so to speak?
Well, that test is pretty recently developed and has just been normed. I mean, as Ed mentioned, we did some work with Nemours.
Yeah, I mean, when you look at the data, you actually, the frequency is going to be certainly less than the 1 in 100 that we could potentially pick up with normative studies. So the difficulty is that these studies cost money. And because anosmia is not perceived as a disability, therefore there is not the funding available to do these large-scale studies. You know, when you look across populations, there is a likelihood that there is going to be a more frequent than expected loss of sense of smell. But individuals who never have had the sense of smell don't have grown up coping without having that sense of smell. And so they are not as likely to seek medical attention as individuals who have always had the sense of smell and then lost it. So the answer to that is we don't know the prevalence in our population. Those studies have to be done. The nice thing is now that those studies can be done. You know, 5 years ago, we couldn't do those studies because we just didn't have the means to look at children and see whether or not they had lost their sense of smell. Now we actually have that possibility, at least down to the age of 3. You know, and that's where we've been. I think it's a potential for population health studies to be done in the future. Dr. Spiegel.
And I have 2 questions for the panel. One is, in terms of this stem cell idea, is there any sense that if you chose that as albeit a small population of patients who have recovered from a loss of smell, post-traumatic, where they get their recovery back 6 months to a year later, would their cells have better potential because they've just been recently been turned on to regenerate than the average normal smelling person in terms of a source for these cells? And the second is, I know that there were some studies done on the real-time PET scans showing sort of the upper neural things that are turned on by the sense of smell and taste, sort of the central nervous system language of smell. And I'm wondering if anybody's done that with anosmic patients, because perhaps these people that would respond to smell even though they don't sense the smell are actually stimulating the same areas of the brain.
Why don't we take the second part of that question first in terms of the functional MRI and PET scan and other studies. Beverly, do you know of anything that has looked at anosmics in terms of is there anything activated when smells are presented, even if there are no smells essentially sensed by the, typical tests?
There have been some studies looking at patients with smell loss. Not necessarily all of them are completely anosmic. One of the difficulties with smell is presenting the stimulus in such a way that the person has to sniff. That's going to activate brain areas. The trigeminal system is often activated even by relatively low-level odorants. So you have to kind of sort all those things out. I think there's one study that did suggest that there were some differences in processing, but I don't know that there's any really definitive work on that, or that they were dealing with anosmics. Off the top of my head, they may have been dealing with hyposmics.
I will say that we have looked at one or two studies at Monell where we've actually taken congenital anosmics and we've done some biopsies of where their olfactory epithelium would be. And we see some disorganized neuroepithelium. We don't know what the meaning of that is, but there is something there that is different than respiratory epithelium. So it's interesting that the connection may not have been made, in those patients, but something exists there, So is there a potential there? That's very difficult to know. The central nervous system pathways are often missing in terms of the olfactory system, so it's hard to know what the end organ changes can be.
And there is actually a fair amount of evidence that the longer you have a smell loss, the more the olfactory bulb deteriorates. So it's measurably smaller.
There needs to be a constant a sensory stimulus to keep neurological systems intact. The first part of the question, addressed to whether or not it would be fascinating to look at individuals who have recovered their sense of smell. I don't know if there's any data really out there, Mira.
That's a very good question. So we can do this in a petri dish, right? We can try to take the stem cells and grow them into neurons, but there's a lot of things that we have to take into account for. Is the microenvironment in our body in itself. So we can replicate in a culture dish, but can we do the same thing in a person? That's a whole other game, right? So that's a very good point, that can we take it from a patient who's recently recovered? So Dr. Pribitkin was saying that there are patients whose smell loss, so maybe they recovered like after 5 years or 6 years. So what changed? What happened? Are the stem cells gone? Are they stimulated now? What's happening? What sort of factors are secreted now? So those are very good questions that we have to look at. And also if the patient recovered because of the stem cells being activated, or is it because the nerves are now miraculously able to reach the brain? So there are a lot of questions that can be posed.
I mean, one thing that we have learned in just the small period of time that we've been doing this work is that some individuals have stem cells that are much easier to culture than other individuals. And there does seem to be an age-related difference, and there also seems in our patient population to be a difference in patients that have been exposed to radioactive iodine and patients that have been exposed to smoke, that they seem, at least in a very small cohort, that perhaps there's a difference in their ability to generate neurospheres in culture. Now, what that means in reality, because none of these people have any smell loss, is difficult to say. But if you have been a smoker or if you have been treated with different types of radiation or radioactive iodine, is it that you might be more susceptible to injury than others? We can't say. These are just experiments outside of the body. We have to translate that into the body, but that's what we hope to do. Well, I want to thank everyone for joining us for this special presentation. Thank you very much.